Greetings, ladies and gentlemen. This is Prosthodontics on Friday, which explains implant prosthodontic steps and its side effects in a very easy and interesting way. This is the 30th Prosthodontics on Friday. Professor Choi Yu-sung of Dankook University Prosthodontics Department is going to talk about customized cementation protocol according to implant restorative materials. Welcome. Thank you for coming all the way from Cheonan. Could you briefly explain about your lecture? Yes. I'm going to talk about customized cementation protocol according to implant restorative materials in an effective way. We take impression of implant prosthesis and through various steps. The final stage is cementation. When we do cementation, if we make the wrong choice or make a mistake, it can lead to catastrophe. I look forward to your lecture so that we be able to learn how to do cementation correctly. Thank you. Dear viewers watching the program on Dental's site, you can ask your questions on the chat screen on the right side of the site. Please feel free to leave your questions and these will be addressed during the Q&A session. Those who have been selected will be given Starbucks coffee coupon. I look forward to your keen interest. Let's begin Professor Choi's lecture. Greetings, I'm Professor Choi Yu-sung of Dankook University Prosthodontics Department. Thank you for giving me the opportunity to present in front of you. Thank you, Professor Cho. Today, I'm going to talk about customized cementation protocol depending on implant restorative material. These are the contents. This is the introduction. Currently, the restorative material and cement have been improved in terms of performance and procedures. And you need to continue to update information on new restorative material and cement material, as well as change protocol to provide accurate cementation for successful implant restoration. Today, I'd like to share information on cement materials that can be applied depending on different implant restorative material and effective protocols that can be applied. Let's look at the different characteristics of cement for dental purposes. Before final cementation, in the case evaluation is needed by setting the restoration, you can use temporary cement, and depending on different characteristics, you need to choose the temporary cement wisely. Currently, the cement for dental purposes can be divided as shown depending on the composition. Zinc phosphate cement is the oldest cement and it has superior compressive strength and low film thickness, but it is opaque and therefore it should not be applied to ceramic restoration. In the case of zinc silicophosphate cement, it is comparatively semi-opaque and it prevents secondary caries. However, acid can cause pulp irritation and therefore appropriate prevention is necessary. In the case of polycarboxylate cement, it can chemically bind with tooth structure and its retention is satisfactory. However, it has low dentin bonding strength and does not bind with gold. Professor Choi, can I ask you a question? Yes? If you look over here, zinc polycarboxylate cement, it says it has good binding strength with non-precious metal, alloy like stainless steel crown. Is there a special mechanism? Thank you for the nice question. In general, zinc polycarboxylate cement is known to have good binding strength with non-precious metal alloy, such as stainless steel, and the reason is within the cement, In non-precious metal alloy like nickel chrome, there's metal ions like silver, bronze, and steel. They make a chemical response and chemical binding is possible. However, in the case of ceramic, it does not have metal ions and no chemical response. It remains unstable and only mechanical binding is possible. Chelation chemical response is made with non-precious metal and binding strength increases. Thank you. I learned so much. Please carry on. Understood? Now I'm going to proceed. In the case of glass ionomer cement, it has low pulpal irritation and it has fluoride release and it prevents secondary caries. However, it does not have resistance against moisture and moisture proofing it is necessary. RMGI is a cement that is used most frequently these days. It has low solubility, micro leakage, fluoride release, and low post-operative sensitivity. However, it should be restricted on use for all ceramic restorations, and it is related to absorption of moisture and expansion. There's high possibility of that. In the case of resin cement, due to extraordinary development in aesthetic dentistry, it is being used more frequently. For effective cementation of ceramic restoration in which aesthetics is emphasized, the cement's mechanical strength and aestheticity is very important in clinical success. Developments have been made on the front of binding characteristic between dentin and ceramic, as well as different adhesive resin cements. In terms of clinical and aesthetic treatment, ceramic materials have developed, and due to improvement in physical property of resin cement, there's an active transition from PFG and PFM to all ceramic. Currently, there are different types of resin cement available and the characteristics differ depending on the product, and you should follow the recommendations provided by the vendor. You need to understand the different cementation procedures for different materials. I have explained the characteristics of different cement. You need to understand the characteristics of each cement and choose appropriate cement that fits the characteristics of restorative material to get good clinical result. Next, I'm going to talk in general about cementation. Before resin cement was developed, zinc phosphate cement was widely used as dental cement. Glass ionomer cement, as well as resin-modified glass ionomer cement with improved physical property were introduced, as well as different resin cements. Gradually, adhesive resin cement are taking the place of existing cements. The currently used adhesive resin cement includes glass ionomer cement, which is acid-base, and composite resin cement, which uses polymerization, and hybrid cement, which include RMGI and conformer. Let's summarize. It has the following characteristics. When you choose and apply dental cement, you need to be aware of these characteristics and how to apply them. Currently, clinically, high binding strength and aestheticity, if it is required, composite resin cement is chosen. If cement, which is easy to manipulate, is required, RMGI cement is mainly chosen. In the case of appropriate abutment shape and traditional cast restoration, it doesn't matter which cement you use, however. I would like to talk about when you should choose resin cement over different cements in terms of restoring implant prosthesis clinically. As shown, if the degree of taper is big, the retention goes down drastically, and this needs to be minimized and length needs to be sufficiently maintained. However, if necessary, you need to use resin cement with high adhesive strength to reinforce retention. If such reinforcement is necessary, you need to consider ways to maximize cementation with implant abutment and restoration. To do this, you need surface treatment on the abutment and restoration. To get good cementation, the following 5 factors need to be satisfied. I'm going to talk about ways to achieve this. Surface treatment of implant restoration is very important, and the inner surface can be cleaned using steam cleaner or ultrasonic cleaner. Surface treatment can be done using mechanical methods such as sandblasting and chemical way like tin coating, or you can do both. Implant abutment should also be subject to surface treatment if necessary. You can use equipment for surface treatment. However, if you don't have it, you can use products available along with the cement. Additionally, in the case of ceramic restoration, for appropriate surface treatment, you need to etch the surface with hydrofluoric acid. Apply silane coupling agent to increase the adhesion between ceramic and resin. However, in the case of zirconia, it does not respond to hydrofluoric acid, and therefore, mechanical wear via Rokatech or Cojet is necessary to increase the roughness. In the case of resin-type materials, curing does not occur due to oxygen if it is in contact with air. The thin layer is called oxygen inhibition layer, and in order to prevent this, the following gel needs to be applied during the curing process. In the case of aesthetic prosthesis which resemble tooth color, it is not just about recreating tooth color, but by giving it transparency, you need to give it that natural feel. In order to do this, you need to use cement with transparent characteristics. On the slide is all ceramic restorations, which show transparency of adhesive cement and utilization of natural color. You need to use resin-type cement with transparency for aesthetic prosthesis. As shown, cement, which is an essential element in aesthetic restoration, has different color and transparency, and in the case of restoration with high transparency, this is very important. Among these products, at times, curing can affect discoloration of restoration, and there's a study on this. Light curing cement to show the least amount of change. As restorative material for dental purposes, improve various ceramic restoration, fabrication, and clinical application have become possible. The process for surface treatment method and cementation process for ceramic restoration have become more simplified. I have talked about overall cementation. In the case of appropriate abutment and to conventional cast restoration, you can use whatever cement available. However, there are cases where resin cement needs to be chosen clinically, and due consideration should be made. Next, I'm going to talk about cementation procedure by implant restorative material. If you divide implant restorative material by abutment, first, there's conventional UCLA abutment with gold and PFM restoration. Titanium abutment with gold and PFM or zirconia restoration, that's the general way. Zirconia abutment with zirconia or glass ceramic restoration with high aesthetic value. Applying dental cement depending on implant restorative materials. The procedure varies depending on different cements, so you need to understand the recommendation provided by the vendor. First, I'm going to talk about UCLA abutment with gold and PFM restoration, which is the conventional restorative material. For cement-type implant prosthesis, to prepare for the case where restoration may be needed to be removed, non-eugenol resin type temporary cement is used. Also, when final cementation is required, in the case of gold and PFM restoration, they're opaque, therefore RMGI cement or self-curing resin cement should be applied. In this example, I'm going to use Premier Implant cement, which is non-eugenol resin type temporary cement. You clean and sandblast the inner surface of restoration, connect the abutment, clean it, and then do the sealing. Premier Implant cement, small amount should be applied, and once the restoration is placed, before cement is set, excess is removed. Finally, once it is set, check the margin and occlusion and conduct the final polishing. Next, I'm going to give you an example of usage of Fujisem 2 from GC4, which is an RMGI cement, for final cementation. Cementing implant restoration with Fujisem 2 is very similar to that of doing it with natural tooth. The inner surface, you sandblast it and clean it, place the abutment, clean it, and seal. Mix Fujisem 2, dispense it on the restoration. Once cement becomes rubbery, remove excess cement. After final cementation, remove excess cement. Check the occlusion as well as marginal fitness. In summary, gold, PFM restoration, you need to do sandblasting and if necessary, use the products. Connect the UCLA abutment, clean it, seal, isolate the abutment, and cement it using Premier Implant cement. Next, I'm going to talk about titanium abutment with gold and PFM restoration cementation. As mentioned earlier, in the case of gold and PFM restoration, it is opaque and therefore self-curing resin cement or RMGI cement is recommended. In this example, I'm going to use multi-link speed from Ivoclar Vivadent, which is a self-curing resin cement, and this is a selective light curing system. Place the abutment and try in the restoration to check the fit and occlusion. The inner surface of the restoration, you need to sandblast and clean, connect the abutment, and after cleaning, seal it. If necessary, apply Monobond N, which is surface treatment agent for restoration and abutment. Use multi-link speed on the inner surface of restoration and place this restoration. Conduct a tack curing and remove excess cement. In order to prevent oxygen inhibition layer, in the margin, apply liquid strip and after curing, check occlusion and margin fitness. After re-evaluation, conduct the final polishing. After that, I'm going to talk about an example using Rely X from 3M, which is a RMGI cement. Do sandblasting and cleaning on the inner surface, connect the abutment, do cleaning and seal. LIX Routine 2 is used to apply on the restoration. After tack curing on each area, remove excess cement. After once it is set, check the margin as well as the occlusion. Do final polishing. In summary, for gold and PFM restoration, do sandblasting, and if necessary, apply products for the restoration. Connect the titanium abutment, clean and seal, and apply surface treatment agent. Isolate abutment, use multi-link speed for final cementation, and if necessary, do light curing. Next, I'm going to talk about titanium abutment and zirconia restoration cementation procedure. Zirconia restoration, in general, resin cement is used for cementation. Unlike a glass ceramic, during inner surface treatment, it is not eroded with hydrofluoric acid. So, Locatec or Cosette system is used for sandblasting. In order to cement the zirconia restoration, self-adhesive resin cement is used commonly. In this example, Rely-X U200 from 3M, which is a dual curing resin cement, will be used. The inner surface of restoration, sandblasting and cleaning is done. Abutment is placed, cleaning and sealing is done. If necessary, surface treating agent is applied to restoration and abutment. Rely-X U200 is mixed and applied to restoration. Once it is placed, the tack curing is done for each area and remove excess cement. Once it is set, check the margin and occlusion and do final polishing. Next, I'm going to talk about multi-link N from Ivoclar Vivadent. Because selective light curing is possible, it can do self-curing as well as dual curing. Check the abutment and try in the restoration to check fit and occlusion. For the inner surface, do sandblasting and clean it. Place the abutment, clean and seal. Apply monobond N, which is a surface treatment agent, on the restoration and on the abutment. Mix multi-link N primer A and B and apply it on the entire surface. Using multi-link N, apply it on the inner surface and place the restoration. Conduct the tack curing and remove excess cement. On the margin, apply liquid strip, and after curing, check occlusion as well as marginal fitness. After re-evaluation, do final polishing. In summary, for zirconia restoration, sandblast. If necessary, use restoration primer and connect the titanium abutment, clean and seal, and if necessary, use the surface treatment agent. Isolate the abutment and use Rely-X U200 to do final cementation in a dual curing way. Professor Che, a lot of people use zirconia crown as implant restorative material. I believe the titanium abutment and zirconia crown is truly mainstream. A lot of people use it. You have explained it very well just now. Could you clarify once again for the viewers? In your case, in the case of titanium abutment and zirconia crown, how do you do it inner surface treatment and which kind of cement do you use? Could you emphasize once again? I would like to answer in two different possibilities. If the titanium abutment has sufficient retention, I would do additional work on titanium abutment, and on the inner surface of zirconia restoration, when I do sandblasting, I would do it with something with silica component like a Cojet or Locatec. Is there something I need to choose in terms of molecule? The molecule is defined in Locatec and Cojet. Use that for sandblasting and apply zirconia primer for better effect. Use Unisem or multi-link speed and other self-adhesive resin cement to get appropriate retention. More than light curing, you recommended self-adhesive. Light curing is okay, but in general, dual curing resin cement is used. For marginal area, Teco-Cure is done ahead, and after that, excess cement is removed, and then do self-adhesive curing. If retention is additionally necessary, conduct a surface treatment both on titanium abutment and zirconia restoration. For titanium, do alumina sandblasting of 50 micrometer, and then apply metal primer to do pre-treatment to increase the adhesive force. In the case of zirconia restoration, as mentioned before, sandblast molecules like Cojet or Rocotec. Apply zirconia primer for pre-treatment. As mentioned before, use Unisem, which is a self-adhesive resin cement, or you could also use multi-link speed. If you want to secure more retention for zirconia abutment, the zirconia's composition itself binds very well with MDP, so use a Panavia F2.0 cement to increase the retentive force. Thank you. Please carry on. Thank you. I will move on. Now I'm going to talk about zirconia abutment and zirconia restoration and the cementation procedure. As mentioned, a self-adhesive resin cement is used for cementation in the case of zirconia restoration. The cement that is used frequently is Panavia F2.0 by Kura from Japan. It is a resin cement. Let me show you the procedure. ED primer is mixed in the same amount. Apply on the abutment, dry it, mix paste A and B, and apply on the inner surface zirconia, which was sandblasted. Do tack curing on each area, remove excess cement, and use OxyGuard. And final setting is done in a dual curing method. To summarize, for zirconia restoration, do sandblasting. If necessary, apply primer with zirconia abutment in place, clean and seal, and use ED primer tool, which is surface treatment agent, to do surface treatment. After isolating abutment, use Panavia F2.0, do final setting in a dual curing method. Next is cementation for zirconia abutment and glass ceramic restoration. Let's look at the procedure. Glass ceramic is a very aesthetic ceramic restoration, and therefore light curing or dual curing resin cement should be imperatively used for aesthetics. Evoclar Vivadent's Variolink N, which is a dual curing resin cement, was used in this example. Abutment was placed, restoration was tried in, aesthetics, fit, and occlusion was evaluated. Abutment was cleaned and sealed, and 5% hydrofluoric acid etching was done on the internal surface. On the restoration, apply monobond N, and on abutment, monobond N, and Excite FDSC is used for silane and bonding. Variolink N, which is a mixture of base and catalyst, is applied on the inner surface of restoration. Abutment is placed, tap curing is done after initial setting. Remove excess cement and apply liquid strip on the margin. After curing, check aesthetics, occlusion, and marginal fitness and do final polishing. To summarize, on glass ceramic restoration, etch using 5% fluoride. Monobond N is applied. Place zirconia abutment, clean and seal. Monobond N and Excite FDSC are used for surface treatment. Isolate abutment and using Variolink N dual curing method is used for final fitting. Up until now, we have looked at different implant restorative materials and applying different dental cements. And as mentioned before, you need to understand the characteristics of different cement. It is very important to understand and follow the guidelines provided by the vendor. Conclusion. As mentioned earlier, you need to understand the different characteristics of different implant restorative material and choose cement accordingly to get good prognosis and good clinical results. In order to achieve this, you need to continue to update the information on implant restorative material and cement material, and you need to conduct appropriate surface treatment for the abutment and inner surface treatment for the restoration to provide successful and durable restorative treatment. Thank you for listening. Thank you, Professor, for the wonderful lecture. I believe I have mastered the topic of cement. Thank you. Now we will close the session for Professor Che's lecture, and via real-time Q&A, we will address your questions. Now let's look at the real-time chat and Q&As on the website. Dr. Kim, I really love the lecture. ID Yadho, nice to meet you, Professor Che. ID Strong Teeth, you look beautiful, Professor Che. I came to say hi to you, Professor. It's a very interesting topic. I really enjoyed today's program by Prosthodontics Spock. ID Hollow, there's a question here. These days, a lot of people use cementation type and ER type, or SCRP. For these two types, can you share the cement that you use frequently for and how to use them? This is the question. Thank you. Thank you for the good question. In the posterior area, I normally use a CRP or ER type abutment. I fabricate it. In the interior area, I use cementation type prosthesis. In the posterior area, if the pass is not very good or if the placement position is not very good, if ER type is impossible, I at times use cement type as well. In the interior area, when I use cement type, if I need to reattach it, if I need to do re-cementation frequently, if prognosis is bad or continuous evaluation is necessary, as mentioned in the beginning, I use Premier Implant Cement. This is a temporary cement, however, this is a non-eugenol type resin cement. I use this when regular checkup is necessary and prosthesis can be removed. In the case of posterior area, SCRP type or ER type, I normally use resin cement, but as Professor Cho has questioned, if the retention is very low, titanium abutment or zirconia abutment needs to be sandblasted and you need to apply product for the restoration there. You need to do surface treatment as much as possible, and on the zirconia restoration or PFM or PFQ itself, you need to do sandblasting and do primer and use resin cement. In the case you don't require a lot of retention, you can use your self-adhesive cement and use Rely X U200 or multi-link speed for cementation. If it requires a lot of retention, as mentioned earlier, MDP is included in Panavia F, and this is used for cementation. If the length of the abutment is long, it's not a big problem. However, it is short, it's a big problem, yes. In the case of posterior area, it needs to be cemented well. In that case, we use resin cement, and in the adjacent crown and abutment, we do mechanical treatment. In my opinion, providing a groove uncustomized abutment can be also a good option. That is correct. You can make a groove to provide retention or minimize the degree of taper. Make the taper about 6 degrees so that you can get more retention for the abutment. Thank you. Strong teeth, I think this is very important. IDU, I really enjoy prosthodontics on Friday. 2875-8282. I think this is a dentist. I really enjoyed prosthodontics on Friday with Professor Cho and Professor Che. Leland. In the case of discolored tooth like that of anterior tooth which has gone through endo treatment or the tooth with titanium abutment, when you restore with all ceramic crown, discoloration of abutment at times is show through. Can we solve this with adhesive cement? This is the question. Yes, thank you for the nice question. In the case of anterior tooth which has gone through endodontic treatment, if the abutment has been discolored, if it is very severe, bleaching is required. Do bleaching first. In order to solve the issue of discoloration, bleaching is required first to alleviate the issue. Before restoration is done, if you cannot adjust it using bleaching or if bleaching is not an option, and if the restoration is all ceramic crown, it is very difficult to block out discoloration. Therefore, using colorless crown is better. PFM or PFG should be used with colorless so that margin is not shown. Or else, black bit, the discoloration may show through soft tissue. If discoloration is improved to the level it can be blocked out, in that case, a zirconia restoration, it lacks in transparency and therefore it is difficult to use in aesthetic restoration. You need to choose glass ceramic in order to block out discoloration and provide an aesthetic restoration. In general, when you use glass ceramic restoration for cementation, it is already bleached, but if it is not or if there is discoloration, you need to use trial paste so that it can be checked ahead whether cement can improve the situation. Use resin cement with trial paste. There's also opaque cement. If you look at Variolink N, there's trial paste, bleach shade. Determine if the situation can be mended with bleaching shade. If possible, use that product. If it cannot be rectified, if it is more severe, as Professor has mentioned, you can use opaque cement. As mentioned earlier, Panavia F can be used for zirconia restoration as well as glass ceramic. It's opaque shade, and opaque shade only exists in paste B. Paste A and B needs to be mixed to be activated. You use paste B first to cement it. Give it a try. If it does not require bleaching and if there's no translucency and if discoloration can be blocked, you can use that as well. Thank you. Thank you. Hygienist Kim Sana. On Wednesday, I do Wednesday seminar, and on Friday, I do prosthodontics on Friday. ID Elaine, is there a difference in cementation strength depending on prosthodontic materials such as all ceramic and PFM and the way it is polymerized? Okay. To explain about the difference of cementation strength depending on the prosthodontic material, As you have asked, in the case of non-precious metal alloy, it is very chemically unstable and it has metal ions, and therefore it has good chemical response with cement. The best is metal crown, metal or PFM crown, followed by gold alloy, and then ceramic. Zirconia is the worst, and glass ceramic is preferred after gold. So, metal, glass ceramic, and zirconia. And this is the order of the strength in cementation. I have talked about difference in cementation strength depending on the restorative material. However, in general, surface treatment is done and sandblasting is done, mechanical treatment is done, and hydrofluoric acid etching is done as well, and as well as chemical treatment like using primer. And therefore, cementation difference, this can be overcome clinically. All four materials can be used in general for restorations. By polymerization method, I'm thinking you're talking about the self-curing, light curing, and dual curing cement. There's no major difference in terms of polymerization method. By vendor, depending on how it is made, cementation differences are shown. Rather than polymerization method, there are ways to increase the cementation strength by increasing polymerization rate. In order to increase the polymerization rate, in the case of light curing cement, use it on thin or highly transparent material like glass ceramic. In the case of dual curing cement, you can use it on zirconia or PFM restoration. In the case of self-curing cement, you could use it on PFM or gold and has no light penetration. In other words, you need to use cement from a good vendor rather than the whey. You need to increase the polymerization rate using the correct cement. Yes. Sangam Dental Clinic. I thought this was recorded ahead, but now I realize this is live. Amazing. 서산두리 Dental Clinic. There's a question. In the case of 3M dual cure resin cement, after you mix it and put it in the drawer, it feels less polymerized the next day. In the case of metal restoration where light curing is not possible, what do you think about using 3M dual cure resin cement? I think this person has tried it, and the next day it was not set properly. I think this person is talking about that, yes. 3M dual cure resin cement. I believe it is Rely X U200. In the case of Rely X U200, this is a dual curing resin cement, and this is a type of self-adhesive resin cement as well. Not Rely X U200, but Multilink N, Multilink Speed, or BSEM. The cement that ends with SEM has, as mentioned, a little bit of a limitation in increasing polymerization rate. In general, it is dual curing cement. However, light curing needs to be included. Light curing leads to better cementation strength, even if it is metal. You do tech cure on the marginal area and seal the marginal area and remove excess cement. And finally, you need to do as much as possible. In the case of metal restoration, it in itself, you need to do light curing to increase cementation strength. You need to do light curing in most self-adhesive resin cement, zirconia or glass ceramic. You can use a dual curing resin cement. However, in the case of metal or PFM, like a gold crown, light is not penetrated here, and therefore using a different cement like self-curing resin cement is better. The person has mentioned that after mixing it, he put it in the drawer. If it is in contact with oxygen, does it set slower? As mentioned, putting it in the drawer itself means that there was no light curing. If you put it in the drawer, there's no light and light curing. And therefore, light curing is the beginning of setting in the case of dual curing. Light curing was not there and polymerization was minimized and therefore it was barely done. You need to do light curing in the beginning to make it start. If you leave dual cure resin cement in a shade or a drawer and if there's no light curing, polymerization does not occur much. ID Chang Chun. Listening to Q&A makes me feel like I'm actually there. Can I only do self-curing with 3M dual cure resin cement? Not just self-curing, but you need to do light curing a little bit to improve the polymerization rate and in removing excess cement. Small King Buchon, is there any tip in reducing stress related to shrinkage during resin light curing? Thank you for your question. Resin, the problem with it is that it shrinks during curing and therefore, in order to reduce the level of shrinkage, as mentioned, you need to do light curing. However, doing it too soon is also unfavorable according to study. When you resin cement, I don't do tech curing immediately. I wait about 30 seconds to 1 minute. And once the cement feels like it's setting, if you do light curing then, there will be no problem with the margin and you can increase the polymerization rate. After you do tech curing and remove excessive cement, use liquid strip to prevent oxygen inhibition layer, and if you do that, you'll be able to reduce the shrinkage related to curing. If you want to improve the polymerization rate of resin cement, do tech curing. Delayed tech curing should be done from 30 seconds to 1 minute, and after that, remove excess cement and in the margin, use liquid strip to prevent oxygen inhibition layer. If you do that, you'll be able to improve the polymerization rate. Thank you for your response. Wow, Professor Che, you're an eloquent speaker. Thank you. Every Friday, I find the lecture very meaningful. Hui Jae-jik, nice to meet you two professors. Thank you for sending in a lot of questions. I hope we get as many questions next time around as well. Thank you, Professor Che, for providing such nice response. And to viewers who have participated in the real-time chat. To those of you who have participated in the chat, a lucky draw will be held and coffee coupon will be sent individually. Professor Che, is there a word of advice or a message you'd like to deliver to our peers who have been with us up until late to do proper cementation at the final stage of implant treatment? Some words of encouragement, perhaps. That would be deeply appreciated. Thank you all for listening in on my lecture. I hope you have expanded your horizon on the cementation protocol depending on implant materials. I hope you understand and study the protocols. And in using cement clinically, you need to understand that there are different characteristics of restorative material and cement. As Professor Chua has mentioned, cementation is the final stage of implant restoration. If you fail in cementation, you need to start from scratch. In order to prevent such crisis from happening, you need to understand cementation procedures of cement properly, please refer to the catalog and follow through. Moreover, I would like to express my gratitude to Professor Cho, who is my mentor as well as Training Center Director at Osstem. Thank you once again. Furthermore, thank you for listening in my lecture up until late, and I would like to express my gratitude to Osstem staff who have made this possible. Thank you. Thank you. Thank you for coming all the way to Magok to participate in prosthodontics on Friday's 30th lecture after ending your work from Cheonan. Thank you once again. Thank you. Dear viewers of prosthodontics on Friday, how did you like your lecture with Professor Che? We were able to learn customized cementation method depending on implant abutment material and implant restorative materials, and I believe this was especially meaningful. Regarding the questions that were not answered during the program, these will be addressed via reply. On the first week of November, on Prosthodontics of Friday, we're going to talk under the topic Application of Implant Overdenture Using Locator Attachments. This lecture is going to be given by Dr. Kim Seung of 22nd Century Seoul Dental Clinic. Thank you all for watching up until late. Thank you so much.
제 교수님 수고했습니다.
네, 감사합니다.